people. And as long as the system is not prepared to assume risk, then the risk has to fall on the citizens, and that's just the way it is.
Paul?
Thanks very much. I tend to agree with Jeremy. You know, this whole issue of supply of doctors, for those of you who live in HDB blocks, every single block has got a GP clinic down below. And the GP very often has nothing to do. So what does he do? He turns into a glorified beautician. So he's giving Botox, or he's doing some kind of skin peel and stuff that could be done at the beautician's clinic next door. So what is happening in the system? What is happening actually is that those of you who have seniors who are housemen or medical officers will know, in the past, if the conditions for junior doctors were bad, then the authorities would try and improve conditions for junior doctors. Now, if the junior doctors threaten to leave, the hospital says, sayonara, we can hire someone from India or Philippines who's willing to work for $2,500 a month. You go there, set up your beautician shop, we don't care. So that, unfortunately, is the reality of what is going on right now, is the driving of wages down in this race to the bottom. When I tell my MOs that when I was a first-year MO, I was able to buy a 1,600 square foot freehold apartment in District 10 for $460,000, they look at me as though I came from another planet. You see, because the reality is that this is part of the whole economic infrastructure, and there has been a change. So I think this question, I agree with Jeremy, God knows how many doctors we really need. But I don't think that there's a real absolute shortage of doctors in Singapore. It's a distribution question. Now, back to this question about how much is the premium. The HSTP healthcare plan is a 140-page document. And in there is the statement that the premium is $600 for every Singaporean. It is subsidized for the elderly, for the poor, and for those who are not earning. How did we come up with that figure? My good friend, Dr. Tan Lip Hong, did the calculations based on the total health expenditure divided by the number of people, compulsory expenses, and then worked out how much was the subsidy. And the subsidy is actually based on a different version from the current system, in that if somebody wants to go to the GP to complain, you don't get subsidized, you know, because the acute illnesses are only subsidized at $10 per visit, which accounts for about 10% or 20% of a GP visit. But if you're going for a chronic illness, if you're going for your high blood pressure, then that is subsidized to 90% of the rate. And that was kind of like the basis on which we did the calculations and came up with the figure. Because it's much cheaper for society to have your high blood pressure treated than to have you get a stroke and then deal with the consequences of a stroke. And you know, when you round in the wards, that's why I call my presentation from the ground. When you see people coming in with renal failure and people coming in with stroke, they had high blood pressure for years. A GP told them about it 5 years ago, but they never bothered to get it followed up, or they didn't have the incentive to do so. As Jeremy has written, co-payments when it comes to this kind of thing are actually a disincentive to cost-effective medical care. So that's one of those things that we're trying to address. Thanks.
I think we have time for one more round of questions. Are there any more questions? Yeah, the lady in the back. Anybody else? Please.
Yeah, I'm interested in MediShield top-up.
MediShield
top-up. How is it a sound idea to marry a private and public companies? Because based on my own personal experience, it seems that both are representing different interests. I talked to an insurance company about this MediShield top-up, and it seems that it's not really in line with what I've heard today. How do you define catastrophic illness under the MediShield coverage? When I talk to her, when I look at my whole plan, I'm covered for accident, I'm covered for 30 acute illnesses, but I'm not covered for regular hospitalization for regular illnesses. And then she suggested, okay, MediShield top-up. But then it was rejected because I have a medical history. So my question is really, is it a sound idea to really marry private and public? Because is there a conflict of interest? And then what is the definition of catastrophic illness, if not acute, if not accident?
Okay, thank you. And another question?
Hi, I really enjoyed the presentation, thank you. So what I understand so far from y'all is that, let me try to rephrase this. What I'm trying to ask is that, do you all think that the government's definition of healthcare and our definition of healthcare, because of how both the definitions clashes together, or there's any conflict, is that why we are seeing all the problems we're seeing right now for the 3M model?
Okay, yeah. Thank you. So I think the question, Is there a difference between, is there a different definition of what's healthcare? Huh? I don't think so, right?
No, there is.
There is?
There's a
Okay,
difference.
all right, well, let's take one more question. One more question. Anybody else want to ask the last question?
Prof. Kuan.
I'm the pediatric oncologist from NUH. See, all of you have been talking macro. Let me go down to the ground and talk micro. You see, I haven't ever seen anybody talk about the real reason why we need more doctors. See, when I graduated in 1980 in MD Pediatrics, I was pushed to do care of childhood cancer. So one person, I could do general pediatrics, I could treat leukemia, brain tumor, bone marrow transplant. But now I would need a whole team of 6 doctors to help me, including Dr. Chetan, whom we recruited from India. Yeah, so the life was simpler then because if you have a child with leukemia and the child relapses, you have to tell mommy, I'm sorry, Mrs. Tan, we have nothing more to offer you. Then the family save money, so it's very cheap. Yeah. So, see, one of the big problems with treating cancer is immunosuppression. These kids get infection. So during our time, we treated these kids ourselves. But with time, we realized that these things are getting more difficult. So we recruited people like Ananth, called Ananth. So there's a whole team of ID physicians now.
Yeah.
Maybe about 10 years ago, there was only one. Now there are how many? 6, 7, 8? 8. Yeah, so that's why healthcare is going up. That's why we need more doctors. It's become so bad that my colleague who is running our bone marrow transplant service, she says nowadays the transplant is getting so difficult that I'm my patient's personal physician. She has time to look after only one patient at a time. That is why we need more in the hospitals.
But that's good or bad? It's good, right? I mean, this is progress.
Yeah, that is good. Yeah, we have to actually work harder than before, Paul.
Okay, all right, thank you. Let's just go around. Why don't we start with you, Paul, and then go around the table.
Yeah, okay.
And could you conclude, since this is your last chance to speak, could you conclude by sharing with everybody here, what is the main takeaway you want them to go home with?
Yeah, I think the main takeaway is that we have to have a radical relook at how healthcare is financed, mainly because the current system is unsustainable. Okay, and again, MediSave, a lot has been talked about tweaking MediSave. You know, in medical school, the top students go into orthopedic surgery for some reason or other, probably because it's the most lucrative. So what happens is the orthopedic surgeon sees a 40-year-old and says, hey, you know, you've got a bit of knee pain. You've got all this money sitting in your MediSave. I can fix your knee and give you a titanium knee for $15,000. Then you go ahead, get it done. Next thing you know, he says, wow, you feel so good, I can do the other knee for another $15,000. So there's $30,000 gone. By the time you're 50 years old, you get your first heart attack, you need a stent, you get cancer, there's no more money left in your MediSave. So you've got to start depleting it. And I think that's the asymmetry of information, which is an issue which has to be dealt with. And again, I would disagree with Jeremy, because I think that when you have many levers, you know, it just becomes too complex. It becomes like one of those Rube Goldberg kind of things. and you really need, and like I said, Singapore is a place which specializes in central control. So if we do central control well, and so if we can have a single payer system, I think we will be able to make it work. Thanks.
Thank you, Paul. Jeremy, please.
I don't agree Singapore is good in central control. I think Singapore thinks we're good in central control. So I think something as important as health is far too important to be left to mere politicians. So I would encourage all of you to read up, be informed, because one day it's going to be you, it's going to be your mother, your child. And the big challenge in healthcare was what our young friend said, that really the policymakers' definition of healthcare is radically different from your definition, and really your definition changes when your child is dying. What is appropriate healthcare, what is not? And until, as a society, we can have these difficult conversations, we will always be groping in the dark, with all parties being very unhappy and very unsatisfied. So I think that the take-home message is really, I think there's a need for the national conversation on tangible